Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
So I thought we will we'll talk about evidence-based practice in general, and I thought we should do a few sessions on just discussing or giving an introduction to evidence-based practice. Okay, so this is the first of those talks. So what we'll talk about today is go over what evidence-based practice is, or what EBM is, and why we as surgeons and trainees need to practice evidence-based medicine. And I'll go through some pitfalls in evidence-based medicine that we need to think about. And I'm sure all of you have heard of this phrase, evidence-based medicine and evidence-based practice. And I thought it would be helpful to just refresh some of these basic concepts. Right. So here's the definition of evidence-based practice, right? This was from one of David Sackett's paper. He is considered as one of the fathers of evidence-based practice. And he said, this is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And then he went on to say that this is integrating individual clinical expertise with the best available external clinical evidence from systematic research. Okay, so let's just dwell on that a little bit. So essentially, he says, you make use of, you make use of clinical expertise and best available evidence, put them together along with what the patient would like to have done, and that, in a sense, will help you practice evidence-based medicine. In other words, it'll help you make decisions about the care of your patients. Now, what is a clinical expertise? Now, let's just take something that most surgical trainees would be familiar with, i.e. the setting of acute appendicitis. And let's just think about the diagnosis of acute appendicitis. Now, in the diagnosis of acute appendicitis, I'm sure you'll agree that there is expertise involved, and this expertise incorporates clinical judgment and also proficiency. And you get judgment and proficiency from knowledge about the anatomy of the appendix, the physiology and pathophysiology of appendicitis, the natural history, and so on. And you also get better by practice, by seeing more and more patients with right iliac fossa pain. And with experience, you are able to make better judgments. Okay, so that's common sense. Now, what we are saying, or what the proponents of EBM say, is that this alone isn't sufficient. And you also need to draw upon a data or evidence on diagnostic tests to be able to then decide which diagnostic accuracy studies. They may even be clinical signs like the SOAS sign or the Roth-Singh sign, or blood tests like the CRP and white cell count, or clinical scores like the AAR score, and studies on imaging and so on. So it's important to keep ourselves up to date with the evidence base, in addition to the expertise that we gain with practice and experience, to then decide what to do next in a patient presenting with acute appendicitis. And last but not the least, you have to fit in or include or incorporate patient values in your decision making. It may not necessarily fit in with what you consider best as the next thing to do. For example, if you're thinking of a CT scan, and the patient wants to particularly avoid exposure to radiation, you will need to accommodate their expectations and their preferences. Not to mention specific issues that are important in individual patients, like allergies to contrast or morbid obesity and so on and so forth when you're deciding on, let's say, doing a CT scan. Okay, so why is this important? Now, traditionally, we have relied on books. We've relied on received wisdom and how things are generally done in the place that you did your training. And you often hear people talking about our experience. In our unit, this is how we do it. This is how we've always done it, and it's always worked for us. Now, the problem with that is, as you might imagine, that is considered inadequate. And if you move from one unit to another, you might find that the practices are very different practices with regards to diagnosing appendicitis. And I hope you'll agree that this is also an unreliable sort of set of evidence to base your decisions on. Now, the other issue is that people would often say in the past, when I say past, I mean several decades ago, that this particular test should work because it makes biological sense. There is this pathophysiological rationale for this. But basing your decisions on mechanistic explanations or pathophysiology is often unreliable. And that's why you need evidence-based medicine, because evidence-based medicine tells you to rely on empiric data, not just on theory. Has it actually worked in the real world? Has it actually been tried in patients, and what have the results shown you? Okay. And expertise alone, clinical expertise alone, as we've discussed, is inadequate to guide your decisions without empiric data. A lot of people would say, I base my decisions on my experience, but that experience is also empiric data, and experience is not great data because, as you might imagine, it often depends on your recollection of your experience. And there's good evidence to suggest that if you ignore empiric data, your outcomes may not be optimal. Right. So one of the other problems with clinical expertise is that although with more and more practice and experience, your clinical judgment will improve, your skills, your diagnostic skills, and also in surgery, your technical skills will improve. With experience, with just experience alone, your knowledge of the evidence base may not improve. And actually with age, your knowledge or your staying up to date with current knowledge may actually decline. You can obviously avoid this by regularly refreshing your evidence base, but there is reasonably good data that shows that with age, performance might decline, and that's largely due to people not keeping up with the knowledge base. Right. So, so these are some of the reasons why we need to think about evidence-based medicine and see what best we can do to practice evidence-based medicine. So finding the evidence, understanding the evidence, and then incorporating the evidence, the results of the papers that you read into your practice is therefore very important, but doing this in an effective manner is actually quite difficult, because there's a lot of evidence out there, and finding the good quality, right evidence that answers your questions requires a lot of time and effort. And that process is simplified, I believe, by a good understanding. If you really understand the principles of evidence-based medicine and apply it regularly, then the time and effort is actually minimized. Okay? Now, the first thing you need to think about to set about practicing evidence-based medicine in your day-to-day clinical work is to first think about the kind of questions, clinical questions, where you need help from evidence-based medicine, clinical questions that need answering in your day-to-day practice. And just thinking of appendicitis, I've made a list of a few questions here. So the first question is, can I improve the accuracy of the diagnosis of appendicitis? Right? The second question is, does postoperative use of antibiotics reduce infection? Then you've got a question that asks, do trainees do as well as consultants, or maybe better than consultants, when it comes to looking at outcomes after appendicectomy. Then you might be interested in what's the right way or the optimal way, if there is one right way of securing the base of the appendix. Is post-operative follow-up in secondary care necessary, or can you just discharge patients back to the GP after appendicectomy? If you don't do an operation, what can I use to predict recurrence after conservative management? So these are examples of clinical questions that address practical problems. Now, you could, if you're really interested, ask questions such as, what causes appendicitis? What does the appendix do in terms of its role in the immunological system and its response to bacteria in the gut? Now, these questions aren't necessarily addressing practical problems. They are important, they are interesting, but they're not necessarily practical, right? So these kinds of questions are what are referred to as background questions in the realm of evidence-based practice. The questions that we discussed above, the list above, are referred to as foreground questions. So when you're reading about evidence-based practice and evidence-based medicine, you might come across these kinds of questions called background questions and foreground questions. Now, just focusing on the foreground questions, and that's what we're going to do now, it is useful to classify these foreground questions into 3 or 4 main groups. The first group is questions about diagnosis, and this also includes screening. So is one diagnostic test better than the other? That'd be a typical question. The second group is about interventions and their efficacy and effectiveness. So this falls under the category of therapy and prevention. So is, for example, laparoscopic appendicectomy better than open appendicectomy? That would be a question. Is so one analgesia better than the other? One set of antibiotics better than the other? And so on and so forth. The third kind of question or group of questions, clinical questions that are practical, would fall under the category of prognosis. So what's the prognosis of this particular condition, or what's the natural history of a particular sort of complication? And then there's another miscellaneous group that includes questions relating to etiology, harm, quality of care, quality of life, costs, and so on and so forth. Some of these overlap quite significantly with the first 3 groups that we discussed on diagnosis, therapy, and prognosis. So grouping these questions then would lead you to look for the appropriate study design or the ideal study design that will help you answer the question. And here we're talking about primary research. We're not talking about secondary research or systematic reviews, where you group all primary research on a particular question and then try and collate the evidence and come up with a summary or a summative answer. So, for example, for diagnostic and screening questions, the ideal study would be a prospective study with a blind comparison with your standard. For therapy questions relating to treatment, a randomized controlled trial, as you would expect. For prognosis and prediction, you ideally need a cohort study. And in the miscellaneous category, it really depends on the type of question. For example, for questions relating to incidence or etiology, you would want a cohort study to answer that question. For questions on prevalence, a cross-section study would be ideal. And for questions on the other issues like harm and quality of life and cost, the study design really depends on the kind of question, but usually a randomized controlled trial would be appropriate. Now we'll talk about these study designs in a later talk, but I thought I should introduce you to clinical questions and the ideal study design for different types of clinical questions. Okay, so now a few things to keep in mind when talking about evidence-based medicine. Now, there's a lot of focus on what we call empiric evidence. Empiric evidence relates to evidence that evidence from the real world, evidence from data that is observed, right? So, and many proponents of evidence-based medicine base all of their arguments around having empiric evidence, and very often ignore mechanistic evidence, by which I mean if there's good pathophysiological rationale that something will work, that often gets ignored with the proponent saying, well, there is no RCT evidence and therefore we're not going to employ that treatment. Now, this is often a problem in medical practice when you deal with drugs and medications. But in surgery, we have tended to go with the practice that if something is likely to work, we just get on with it. And a really good example of this in general surgery is the adoption of laparoscopic cholecystectomy. Now, laparoscopic cholecystectomy very rapidly became the norm or the standard in dealing with gallstone disease, without randomized controlled trial evidence saying that laparoscopy is better than open cholecystectomy. And that was because the benefits were very, very obvious. The rationale was there. You didn't have to do a big muscle cutting incision, and that increased inflammation and morbidity and so on. So there was so much mechanistic explanation for it that we didn't really wait for the gold standard randomized controlled trial to come along to show that laparoscopy is better. However, so the point here is that you should not ignore, I think, the pathophysiological rationale. Although if there's empiric evidence that is much better, you should always consider the mechanisms as to how an intervention would work, as opposed to just seeing if it works in the real world. Now, if you are writing a protocol for a Cochrane review, if you're doing a systematic review and meta-analysis as part of a Cochrane review, you will find that the Cochrane want you to write about mechanistic evidence. They want you to write a paragraph or two about how the intervention might work. So obviously, people do give importance to mechanistic evidence, at least the importance it deserves. Right. The second thing to think about is you may have all come across this pyramid of studies that gives you an idea of the importance of different study designs and the levels of evidence they provide in helping you make a particular decision. Now, you might have come across this problem, and the problem is that many of the proponents of EBM would love you to think that the RCT evidence is the best available evidence. It often is, but not always. Now, a poorly performed randomized controlled trial might actually not be that worthwhile or less worthwhile than a well-done cohort study, and that's often ignored. Often evidence from a randomized controlled trial, however poorly it may be done, is used to bin or shut down really good quality observational evidence. And then that's something you need to be aware of. Right. Another thing is another problem, if you like, in the practice of evidence-based medicine is this thing called the inferential gap. So what is this? Now, if you're drawing evidence from randomized controlled trials to make a particular decision, you need to keep in mind that these randomized controlled trials are often done in patients, in selected patients, patients who fit very neatly your inclusion and exclusion criteria that the people who designed the trial have implemented or laid down. And therefore, the results may not necessarily be applicable or generalizable to patients who do not fit those inclusion and exclusion criteria, in patients with some unique problems or complicated circumstances. Now, for example, let's talk about appendicitis. And if you're planning to do a CT for a patient with right headache fossa pain to be able to diagnose appendicitis, and you come across this meta-analysis and review, a Cochrane review that says CT scan is one of the best tools that there is, and the diagnosis of appendicitis is highly sensitive, highly specific, so it really trumps ultrasound and all your clinical scores and CRP and what have you. That may not necessarily be true for the patient in front of you, because the patient in front of you might not be the kind of patient that has been included in the RCTs. For example, you might have a patient that has got contrast and allergy, and therefore you can't do the standard enhanced CT scan. You might have to do a non-contrast CT scan, and the trials and the meta-analysis may not have studied non-contrast CT scans. It may also be that you have a patient that does not like exposure to radiation and would like to be treated or managed without any exposure to radiation. Or the patient might be super obese that does not fit into your hospital CT scanner. And therefore, you have a problem. You have a lot of evidence on a particular diagnostic modality or treatment, but you just can't apply that to the patient in front of you. And for many treatments, from many settings, you will find that randomized controlled trials have actually excluded a significant proportion of patients that you will come across in day-to-day practice. And that's what is referred to as the inferential gap. Okay, the other thing to think about is this difference between statistical significance and clinical significance. Clinical significance is the difference that matters to the clinician and the patient. Statistical significance simply refers to the p-value, the probability that the observed results are due to chance. Okay, so it's important to understand the difference, and we might cover that again in another session. So if you have a small trial, you may have some important clinical differences between groups, but because the trial is small and the numbers aren't great, you might not get the magical p of less than 0.05. On the other end of the problem, you might have very large administrative data sets that are being used to address specific questions, and they might, the results from those studies might give you a significant p-value very easily, even if there is not much difference between arms. So even if the clinical improvement is only marginal, or the clinical effect size is very low, you'll get a significant p-value. So that's something to be aware of. The other issue with trials particularly is that trials tend to measure outcomes, or tend to focus on primary outcomes that are easily measured, not outcomes that need to be measured. And often trials will use surrogate outcomes, because waiting for the final all-important outcome that matters to patients might make the trial too expensive or too lengthy. And in many trials, outcomes do not reflect, even secondary outcomes do not reflect what patients would like to be informed about. And the last thing to keep in mind is that the issue with reporting bias. So articles with negative results don't get published, or are published in very low impact factor journals, and they don't necessarily reach a wide audience. And the fact that there are many studies in the literature, including randomized controlled trials and systematic reviews and meta-analysis, that are poorly done, and the quality of evidence is rather poor. But just because it is published, people will start to quote the systematic review or the meta-analysis and base the results of that poorly conducted study to guide their decisions. Okay, so we've come to the end of this talk. So to summarize, we talked about what evidence-based practice or medicine means. I hope I've explained why it's useful for us to practice evidence-based medicine and how it helps us in our decision making. We went through some kinds of questions that EBM can help in answering. We talked about background questions and foreground questions, and how foreground questions can be grouped into different categories, like questions addressing diagnosis, questions addressing prognosis, and so on. We then talked about some of the pitfalls of evidence-based practice. So keep in mind that we shouldn't ignore pathophysiological explanations or mechanisms, and then only focus on empiric data. We shouldn't do that. You should be aware that RCTs may be poorly done and that observational studies that are done really well might be better than RCTs in many instances. We talked about the inferential gap, where the results of RCTs don't necessarily apply to patients in front of you. We talked about statistical versus clinical significance and how we should be focusing on clinical significance. We talked about outcomes that are not necessarily important, that can be the focus of trials. We talked about low quality evidence and reporting bias. So that's it. That's it for this talk. I hope that was useful. If you do have any questions, let me know.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.